In this video I will explain the hemorrhage. Uncontrolled bleeding will lead to a hypovolemic shock state, or hemorrhagic shock. While hemorrhage and shock often coexist, they are not the same. Patients who are actively bleeding may not yet be in shock. Conversely, patients may be in shock as a consequence of hemorrhage, but they may no longer be actively bleeding. Resuscitation is very different if patients are actively bleeding or if they are not bleeding. In patients who are bleeding, the priority is to stop bleeding. In patients who are not bleeding, the priority shifts to normalizing end-organ perfusion, correcting the shock state. Thus it is vital to recognize patients who are actively bleeding, and this is different from recognizing that a patient is in shock. Hemorrhage must be recognized and managed rapidly and decisively to reduce the severity and duration of shock. Hemorrhage is treated by arresting the bleeding, not by fluid resuscitation or blood transfusion. Although necessary as supportive measures to maintain organ, especially cardiac, perfusion, repeated volume resuscitation of patients who have ongoing hemorrhage will lead to physiological exhaustion, profound coagulopathy, acidosis and hypothermia, and subsequently death. Pathophysiology. In trauma and surgery, the combination of tissue trauma and hypovolemic shock leads to the development of an endogenous coagulopathy called acute traumatic coagulopathy, ATC. Up to 25% of all trauma patients develop ATC within minutes of injury, and it is associated with a fourfold increase in mortality. ATC is characterized by systemic hyperfibrinolysis, low fibrinogen levels, and platelet dysfunction. ATC evolves into a more complex, multifactorial, trauma-induced coagulopathy owing to further derangements induced by resuscitation. Fluid and red blood cell transfusions lead to dilution of coagulation factors, which worsens the pre-existing coagulopathy. Underperfused muscle is unable to generate heat and hypothermia ensues, again worsened by cold fluid or blood transfusion. Further heat is lost by opening body cavities during surgery. Severe acidosis and hypothermia both inhibit coagulation proteases and reduce coagulation function. These then lead to further bleeding and a downward spiral, leading to physiological exhaustion and death. Definitions. Revealed and concealed hemorrhage. Hemorrhage may be revealed or concealed. Revealed hemorrhage is obvious external hemorrhage, such as exsanguination from an open arterial wound or from massive hematemesis from a duodenal ulcer. Concealed hemorrhage is contained within the body cavity and must be suspected, actively investigated and controlled. In trauma, hemorrhage may be concealed within the chest, abdomen, pelvis, retroperitoneum or in the limbs with contained vascular injury or associated with long bone fractures. Examples of non-traumatic concealed hemorrhage include occult gastrointestinal bleeding or ruptured aortic aneurysm. Primary, reactionary and secondary. Hemorrhage. Primary hemorrhage is hemorrhage occurring immediately as a result of an injury or surgery. Reactionary hemorrhage is delayed hemorrhage within 24 hours and is usually due to dislodgement of a clot by resuscitation, normalization of blood pressure and vasodilatation. Reactionary hemorrhage may also be due to technical failure, such as slippage of a ligature. Secondary hemorrhage is due to sloughing of the wall of a vessel. It usually occurs 7 to 14 days after injury and is precipitated by factors such as infection, pressure necrosis, such as from a drain, or malignancy. Surgical and non-surgical hemorrhage. Surgical hemorrhage is due to a direct injury and is amenable to surgical control, e.g. suture ligation or other techniques such as angioembolization. Non-surgical hemorrhage is general bleeding from raw surfaces and mucous membranes due to coagulopathy and cannot be stopped by surgical means, except packing. Treatment requires correction of the coagulation abnormalities. Diagnosis of active bleeding, response to fluid. Therapy. The mode of resuscitation is determined by whether patients are actively bleeding, which requires a dynamic assessment of the blood pressure response to volume infusion. Patients who are non-responders or transient responders are still bleeding and must have the site of hemorrhage identified and controlled. Responder. There is a good and sustained improvement in blood pressure in response to a bolus transfusion. Transient responder. There is an improvement in the blood pressure, but this is not sustained. The rate of hemorrhage is less than the rate of volume administration. Non-responder. There is no improvement in the blood pressure to a bolus transfusion. The rate of hemorrhage is greater than the rate of volume administration. Degree of hemorrhage and classification. The adult human has approximately 5 liters of blood, 70 milliliters per kilogram for children and adults, 80 milliliters per kilogram for neonates. Estimation of the amount of blood that has been lost is difficult, inaccurate, and usually underestimates the actual value. External hemorrhage is obvious, but it may be difficult to estimate the actual volume lost. In the operating theatre, blood collected in suction apparatus can be measured and swabs soaked in blood weighed. The hemoglobin level is a poor indicator of the degree of hemorrhage because it represents a concentration and not an absolute amount. In the early stages of rapid hemorrhage, the hemoglobin concentration is unchanged, as whole blood is lost. Later, as fluid shifts from the intracellular and interstitial spaces into the vascular compartment, the hemoglobin and hematocrit levels will fall. The amount of hemorrhage is historically classified into classes 1 to 4 based on the estimated blood loss required to produce certain physiological compensatory changes. Although conceptually useful, this classification system is never applied clinically, and indeed is difficult if not impossible to determine. There is variation in clinical response across ages. The young compensate well, the old very poorly. Variation among individuals, e.g. athletes versus the obese, and variation owing to confounding factors, e.g. concomitant medications, pain. Hemorrhage resuscitation. The conduct and goals of resuscitation change depending on whether the patient is actively bleeding. In this case, the resuscitation focuses on achieving rapid hemostasis and maintaining the ability of the blood to clot. This paradigm is called damage control resuscitation. See damage control resuscitation. If the patient is not actively bleeding, has stopped bleeding, or the cause of shock is not hemorrhage, then resuscitation is directed at correcting the shock state and restoring perfusion to end organs. Identify hemorrhage. External hemorrhage may be obvious, but the diagnosis of concealed hemorrhage may be more difficult. Any shock should be assumed to be hypovolemic until proven otherwise, and, similarly, hypovolemia should be assumed to be due to hemorrhage until this has been excluded. Once hemorrhage has been identified, the institution's major hemorrhage protocol should be activated, which will specify the approach to damage control resuscitation. Immediate resuscitative measures include the assessment of airway and breathing and control of life-threatening issues as necessary. Large-bore intravenous access should be instituted and blood drawn for cross-matching. See cross-matching. Transfusion should start with emergency type O blood. See transfusion. Once hemorrhage has been considered, the site of hemorrhage must be rapidly identified. Note that this is not to identify the exact location definitively, but rather to define the next step in hemorrhage control, operation, angioembolizer, tie-on, endoscopic control. Clues may be in the history, previous episodes, known aneurysm, nonsteroidal therapy for gastrointestinal bleeding, or examination, nature of blood fresh, melena, abdominal tenderness, etc. For shocked trauma patients, the external signs of injury may suggest internal hemorrhage, but hemorrhage into a body cavity, thorax, abdomen, must be excluded with rapid investigations, chest and pelvis radiographs, abdominal ultrasound. Investigations for blood loss must be appropriate to the patient's physiological condition. Rapid bedside tests such as ultrasound are more appropriate for profound shock and exsanguinating hemorrhage than investigations such as computed tomography. Patients who are not actively bleeding can have a more methodical, definitive workup. Damage control resuscitation. Damage control resuscitation, DCR, also known as hemostatic resuscitation, is a paradigm that prioritizes hemorrhage control in patients who are still actively bleeding. The rationale is that no aspect of the shock state, end organ perfusion, blood pressure, temperature, lactic acidosis can be corrected while patients are bleeding, and repeated cycles of volume resuscitation will exacerbate coagulopathy, hyperthermia and metabolic derangements, acidosis, hyperkalemia, hypercalcemia. The introduction of DCR has been associated with substantial reductions in mortality from hemorrhagic shock in the last decade. DCR applies only while patients are bleeding and is based on 4 key principles: rapid hemorrhage control, permissive hypertension, avoiding dilutional coagulopathy, and treating existing coagulation deficits. Figure 2.2. Rapid hemorrhage control. At all times, control of bleeding is the priority. Direct pressure should be placed over the site of external hemorrhage. Temporary bleeding control should be achieved with tourniquets, balloon occlusion, or other techniques. Intracavitary hemorrhage should be suspected and searched for, and the pathway should actively move patients forwards to the operating theatre or interventional radiology room to achieve this. The damage control approach is extended to the conduct of surgery to prioritize rapid bleeding control. In damage control surgery, surgical intervention is limited to the minimum necessary to stop bleeding and control sepsis, in order to avoid additional tissue damage, bleeding and physiological stress. More definitive repairs can be delayed until the patient is hemodynamically stable and physiologically capable of sustaining the procedure. Thus, the operation is tailored to match the patient's physiology and is not focused on reconstructing anatomy. Damage control is a term borrowed from the military. It ensures continued functioning of a damaged ship above conducting complete repairs, which would prevent rapid return to battle. Summary Box 2.3. Damage control surgery. Arrest hemorrhage. Control sepsis. Protect from further injury. Nothing else. Permissive hypertension. Permissive hypertension allows the patient to set their own blood pressure while bleeding and avoids continued volume resuscitation in the vein attempt to normalize perfusion while bleeding. This reduces blood loss from bleeding sites and reduces dilutional coagulopathy and hyperthermia induced by fluids. It is important to maintain baseline perfusion of the coronary arteries at minimum, and thus a palpable central pulse, mean arterial pressure above 50 mmHg, must be maintained by whatever means are available. Avoid dilutional coagulopathy. Avoid dilutional coagulopathy by avoiding clear fluids, crystalloids or colloids, and by giving a transfusion that approximates whole blood, usually administered as equal volumes of packed red blood cells and plasma. Treat existing coagulation deficits. Treat existing coagulopathies either empirically or by regular coagulation testing and acting on the results. Tranexamic acid should be given as soon as possible in almost all bleeding patients to stop hyperfibrinolysis. Blood component concentrates should be given to correct existing deficits, such as cryoprecipitate for low fibrinogen levels or platelet transfusions for platelet dysfunctions. After hemorrhage control. Once hemorrhage is controlled, patients should be definitively resuscitated, warmed, and have coagulopathy corrected. Attention should be paid to fluid responsiveness and the endpoints of resuscitation to ensure that patients are fully resuscitated and to reduce the incidence and severity of organ failure.